I think from a liability standpoint, this is only protecting physicians, right? I mean, when we're testing people based on, I mean, probably some piece of bias, right? When we're just kind of deciding at whim. I think that's actually a lot worse, right? And now we're subject to our own implicit biases, and those decisions are going to have potentially really adverse effects on certain populations. So by standardizing the testing, I think if anything, it's protecting us. The other piece that I'd mention is that, urine tox testing, it's problematic in and of itself, right? Um, for many reasons. Number one, it's an imperfect test. Like we mentioned earlier, it doesn't tell us anything about a long-standing substance use disorder. It doesn't tell us when necessarily the last use was. And I would say out of all of those, the most important thing is it's not a surrogate for how good of a parent someone is going to be, right? We don't screen arbitrarily for any other medical condition that I can really think of, in pregnant women, but this, for some reason, prior to us being more aware of this, it was deemed acceptable. Like you're here, we're going to text him, do a urine tox screen because we think that you need it. So having a standardized screening test based on history, I mean, really the main trigger for urine tox testing was a patient that said, yeah, I recently used this or that substance. We're really just confirming what a patient is already telling us. And I think that we should feel empowered that we're doing the right thing when we do that. I think the immediate things that can be done, I mean, I'd say one has to do with universal urine toxicology testing. So there are still institutions that test all pregnant women, on admission to the hospital for substances. The American College of says pretty clearly that that's really not recommended. And so I would say if you're an institution that is still doing that, to discontinue that practice would be the first quick and easy thing. And then secondarily, just making sure that there's some kind of protocol set. Like it doesn't have to be iPad based. It doesn't have to have all the bells and whistles, but as long as what you're doing is standardized, meaning that you're screening patients based on A, B, and C criteria and really avoiding things like poor prenatal care or late entry to care, or other demographic variables. Because when we screen using those demographic variables, we are going to still test the same populations that are vulnerable to bias, right? And because we know that race and demographics do cluster in this country, when we screen by those things, particularly for drug testing, it's going to just perpetuate the cycle. It's a really interesting study that they did. I think it was a group at UCSF on a California system where they sort of looked at the demographics of who was being tested before universal screening and then after. And their disparities either stayed the same or I think they even worsened a little bit. But the difference between their screening protocol and what we tried to create was that they're screening on those same things, right? And okay, they had fewer than 3 or 4 prenatal visits, or they didn't enter to care until after 20 weeks. When we do that, we're just perpetuating the same cycle.